Hello, hello, everybody.
Hello.
Hey.
Hello. It makes me so happy to see y'all. Alrighty. So I'm leading today, which is the first time I'm going to lead in a while. So I thought I'd get us started off by doing a couple of videos about what health psychology is, because some of you might never have heard of it before. It really is, like your book says, sort of a combination of clinical and medicine. So most of the time people who get PhDs get a clinical PhD and then go to specialize in this. So I'm going to screen share Blackboard here. Alrighty. And I thought this first one, actually the first two, I'll show you both, are really nice overviews that show you a bunch of different people working on these. Oh, and I just realized I'm going to need to reshare because I didn't share my sound. There we go. Now you'll be able to hear it. Okay, so this is made by the American Psychological Association, so it has several different health psychologists in it who talk about their role. And then, like I said, I have another one from the same series I'll also show you all before we start discussing things. So I'm gonna start this playing.
Overall health within
Again.
behavioral health services is such a critical part of overall health. Within family medicine, a large percentage of patients come in with medical problems that put them at risk for behavioral diagnosis like depression.
Depression is the #1 complication of childbirth.
The numbers of children that have unmet behavioral and developmental needs is staggering.
We know there's an unmet need in our community. Let's go ahead and address it.
There's a lot of energy around integrated care, and I think there's a lot of good reasons to believe that sort of reconnecting the mind and the body and caring for them as one is going to lead to better outcomes.
It offers way more seamless service. It gives me an opportunity to always have the physicians in the office. We can consult, they know the families, I know the families, and we come together and we just provide a much better service to the families.
I love practicing this way because I have the doctors as a resource.
The longer we work together, the more expert we each get at what the other one does.
In terms of having their medical record, you have so much more context and you have a team to work with.
So what it's allowed me to do is see patients more efficiently and see them more effectively. We're able to reduce a lot of barriers to care.
You can't tell, looking at our patients in the waiting room, who's here to see who. So I think the stigma goes completely away. It's a godsend.
We really have an opportunity for constant collaboration, feeling like we're really a true member of the medical team.
There's that capacity that gets built and that comfort level that comes from practicing together.
We raise each other's skill set.
We need psychologists in private practice. We need psychologists working in mental health clinics to be able to care for our patients, but we also need psychologists in primary care settings.
It's a great model. I can't think of doing psychology outside of the model that we do it here in an integrated care model.
I could not imagine nor want to practice in any other way.
This is just good preventive health. It's good health care. Most importantly, it's what we ought to be doing.
You know, it takes a village to raise children. Well, they're part of my village.
Most of the things that are making people sick today, it's not communicable disease, it's behavior. And so we need more physicians that are prepared to help patients change behavior.
There's lots of good that can be done by bringing
different professionals together, by working closely in partnership with patients and their families, by getting out of the office and going to the home setting, and then by actually better coordinating care across healthcare settings.
Which means they get highly coordinated, highly concentrated care.
What makes this, for me, an ideal place to work is that we have providers from many disciplines.
Usually there's a physician intensely involved, there's at least a nurse case manager, we have social work involved, we have pharmacy involved, we have psychology very well involved.
It's a pretty big team dedicated to providing families services that they need.
I think the challenge of the future for physicians will be, how do you participate in a team? How do you do collaboration? How do you involve yourself with other expertise and use it and make yourself available to it?
Collaboration is the only way it works. We have had care teams that will meet and actually discuss certain patients in each of the offices. So they'll have the psychologist, one of the physicians, the care coordinator, somebody from the nursing staff, and they'll actually meet and sit and discuss the more complex patients to try to meet those needs.
There are some conditions where having a robust set of practitioners with different skill sets on a team makes an incredibly significant difference in outcomes for that specific patient. And I think we've seen that happen quite a bit.
What I think is crucial is the level of expertise on the team, that you don't have to have somebody with a doctoral degree delivering every piece of the service. What you do have to have is a substantial well of expertise when it doesn't go by the book.
We all come to the table sort of knowing what those various levels of expertise are and appreciating that they all just grow and expand by virtue of collaborating. I'm part of the super utilizer team, the team of a nurse who's the case manager, the fellow who's an MD, pharmacy students, myself, and we kind of all work together.
We will actually meet before patient sessions and go over behavioral aspects of the patients that we will be seeing that day, almost like a pre-rounding approach, and discuss psychopharmacology and different options for the patient as well, which is very helpful.
I think we promote in all of our health centers a living laboratory of multidisciplinary, education.
It's best to be training psychologists and physicians who are going to work together, to be training them together so that we learn to talk the same language and we learn each other's strengths and we learn the skill sets and how to best use them and work together.
The longer we work together, the more expert we each get at what the other one does.
We improve the quality of patients' lives and we keep them out of the hospital, and that is, very passionate about this work.
You're muted.
Thank you. That took me way too long to process. It's a day, y'all. So yeah, initial reactions to what health psych and behavioral medicine are. Is this something you were familiar with at all? What questions do you have about this subfield? What's your impression of how it works? Yeah, Colin, go ahead.
So I'm actually reading a book right now called The End of Mental Illness by Dr. Daniel Amen, who runs Amen Clinics, and they use SPECT scans and stuff to scan your brain, and they're big into looking at your overall health history, figuring out why your SPECT scans look the way they do, if there's overactivity or underactivity in certain areas or whatever. And it just made me think of that, head trauma. Have you been around toxic fumes or whatever, throughout your life? You work with cars and stuff, or if you be around drug users and stuff like that. So it made me kind of think of that, look at psychology, trying to look at the entire body and not just the mind itself. And, looking at the brain, because that controls our mind.
Yeah, that's a really good point, is that, that we're realizing more and more that there is this mind-body connection. One of the articles you read for today was actually published in 1990, right, when this field was sort of new. And everything written in there is pretty much still accurate. We're still figuring stuff out. Certainly we've advanced a little further beyond there, but, the brain is one of the unexplored frontiers. It's like the brain, deep space, and the deep ocean. So there's still a lot we don't know. We'll put it that way. Other thoughts about health?
When doing one of the Blackboard readings, health psychology, the science in the field, was when I kind of understood what health psychology is, why it just made more sense to me, the behavior aspects. If you think about it, if you're stressed, you do certain activities like stress eating, eating fattier foods, smoking, drinking, which can lead to other illnesses down the road. And and the way your brain works is with all of the neurotransmitters in there, oh, that sugary food that made you feel better, you can eat it again and you'll feel better now, and just it just reinforces that behavior. So yeah, it really makes sense to me why health psychologists are important in helping people understand their health and trying to improve their health.
Yeah, I think that's a really good point. Charleston first, and then we'll go to Zoe, then Miranda.
Yes, ma'am. The question is, how is this, because maybe they said in a video and maybe I didn't grasp it when it was said, is this clinical psychology? I mean, I understand what psychology is, but this would be a degree in clinical psychology, correct?
Yes, yeah. So typically you get a degree in either clinical or counseling psychology, and then just like forensic psychology, how we talked about it last week, you would then so your training experiences while you were there, your internship, if you decide to do a postdoc, you would all focus more on health psych.
Right. Okay. Thank you.
Yeah, and there are some master's programs in health psych. So that is sort of a growing field. But the majority of the time when you get to the PhD level, it's you get it's interesting because your PhD research is the smallest thing ever, right?
Right.
The PhD fields are pretty broad, right? So my degree is just in clinical psychology, right? And technically my area of focus was adult psychopathology, but it doesn't say that anywhere in my degree or anything, right? So yeah, you just sort of specialize from there.
Okay, thank you so much.
Yeah, no problem. Technically, if I got licensed, I could be a health psychologist. Just where you end up. And I actually do have some experience doing health psych. So I did some on my placement year in grad school. So I did pre-surgical evaluations for people who are going to undergo bariatric surgery. So stomach stapling was what they used to call it, but now they call it gastric bypass, gastric banding, gastric sleeve. I rounded on that placement, and I saw people who came in for physical reasons and or mental reasons. We saw anybody who came in with alcohol in their system, for example. And then when I was on my internship, I did a ton of health psych stuff. So I worked on a spinal cord injury unit. I worked on a blind rehab unit. I did med rehab units of people that had hip replacements or had heart attacks. I did time in clinics for breast cancer, HIV, AIDS, and MS as well. So I have actually a decent amount of experience in this. And it's kind of a fun field because there are so many different directions that can go in. So yeah, next up is Zoe.
So I have two questions for health psychology. When I was reading it in the book, does it all have to be physical health? Because if I was interested in this, I was reading through it and I was like, oh, could be something I do. And then I got down to the part where I was must be able to, be able to lift or potentially help another person. And I was like, okay, well, maybe not, because I'm pretty small. So I was I don't see myself even able to lift another person. Is there different categories, or could you work with people smaller than you, which is I guess kind of weird, but somebody who I could actually potentially help?
Yeah, that's a really good question. So yeah, the bachelor's degree fields here are the ones that are more hands-on. So when I was working as a master's level person, when I was partway through grad school, or as a doctoral person, I didn't touch patients except to shake their hands. So I went in and either like essentially did bedside therapy and assessment, or sometimes I would do even like more elaborate assessments with them. So like I did, I think like memory scale with one of my spinal cord injury people, because they were worried that he might also have some brain issues. Not surprisingly, because the central nervous system's all connected. Yeah, so in fact, I rarely, like did anything physical with patients. I might like walk down the hall with them. Yeah, you don't have to do that physical aspect of it unless you want to do one of those master's level things where you are doing like physical therapy, occupational therapy, things along those lines. But yeah, it was really interesting because, if someone had something really communicable like C. diff, which is a diarrheal disease that tends to go around hospitals a lot, even though we weren't going to touch them just because of protocols, we still had to gown and glove. So I did that quite a bit, going to different patients' rooms. So I'm sure now any health psychologist would have to put on a mask and maybe a face shield as well. Yeah, that's a really good question. Yeah, typically as a psychologist, you're not doing physical things, although there are certainly people who interact in that way. So one of my friends whose sort of specialty was health psychology in grad school, her advisor had a grant to look at mindfulness meditation with people who were recovering from heart attacks. And so she would actually go in while they were doing their cardiac rehab and talk to them then. She wasn't like running on the treadmill next to them, but she'd like stand on the next to the treadmill while they were on it or whatever and try to recruit them for this group. So yeah, you can be in those medical settings, but rarely are we touching people. And in fact, if you wanted to do something more physical with them, you would probably need some other certification and training, because you don't really get any of that as a psychologist. Let's put it that way. You learn about sort of that mind-body connection, but then you leave the other things to the people who are trained to do it. And the really nice thing, and why I like those videos, is that you work most of the time on interdisciplinary teams. So like, I would go to team meetings for the spinal cord injury unit, which was the first time I really saw gallows humor. It was like the only way they could cope, because they would like just make all these jokes that would be like completely inappropriate anywhere else. They never did it in front of the patients, but it's really hard to see people who have lost all of their, functioning from chest down, for example. And so this is the way they coped. I did an interdisciplinary team. This is actually something I forgot to mention, for mild traumatic brain injuries, so concussions, for recently returning vets. So that was like a neurologist, a nurse, a social worker, and me. And we would all evaluate them together. And then I would go to other team meetings as well. So yeah, it's very integrative. And so you're constantly in communication with those other people, which is really cool. Miranda, go ahead.
Building off somewhat of what Zoe said, I used to work some in elder care. And so, it was my job to kind of help lift them and get them out of chairs into the bathroom and all that fun stuff. But I mean, obviously, because I wasn't trained, never did any of the therapeutic side of things. The care team that did do that also very rarely commingled with us. It was usually pretty separate. The elder care technicians would do the hands-on stuff, and then the psychiatric and nursing teams would kind of back off and do more of the health care related side.
Yeah, I know that my interns that have worked in like hospital or nursing home settings in the past, if like their patients they're meeting with need to get up, they have to call a staff member just because of the liability, basically. So yeah, you call someone who's trained, which like, little plug, there are intern spots for next semester. If anyone has questions, I can stick around after class, or you can shoot me an email. But Megan,
sorry,
Miranda.
And also just, I think something that's super intriguing about health psychology is that it's just such a comprehensive view of psychiatric services. Very rarely do we ever treat anything in a vacuum. If someone's pregnant and, they need extra healthcare, you'll have an OBGYN, you'll have, perhaps, blood pressure specialist, because that's a huge thing. You'll have, nutritionists that might help out if that is needed. Very rarely do you ever just kind of serve a person outside of your expertise. And so it's really strange that we treat healthcare that way, or that we, we'll give references, but we don't actively work with their care providers. Even growing up, I had really, really, really bad undiagnosed anxiety when I was a kid, and it manifested as really bad stomach issues. So I lost a ton of weight. I was severely underweight, not because I was anorexic. They thought I was, having an eating disorder. I was just really anxious and couldn't keep stuff down. And because my primary care physician and my I never really had any mental health care, it never really worked together. They were just like, all right, moving on. It never went anywhere. The case was never connected and made until after I was older and had already kind of been treated for anxiety and grown out of it, so to speak.
Yeah,
So,
Miranda makes a
perspective of health psychology is super intriguing.
Yeah, this happens in both directions, honestly, where people will come to the ER with a panic attack and they'll be diagnosed with heart issues, and it takes them forever to figure out it is psychological, right? Or like Miranda's case, someone will be diagnosed with a psychological issue, but they won't do tests to figure out it's physiological. Miranda is doing our discussion leading on Wednesday, and Miranda, there's actually a case that I sent you that's identical to your case growing up, so you might want to use that as one of your cases. Yeah.
Sure, thank you.
And Megan, go ahead.
Yeah, the other thing that I wanted to say was that, I used to my freshman year, I was a pre-med biology major, and in high school, a lot of my friends wanted to be nurses because they liked the quality of care that nursing had, and being with their patients. And but I just didn't know that health psychology was an option of working in hospitals, because you're still providing that care in a medical setting, just in a different way. And I thought that was interesting when watching the video.
Yeah. I mean, it's honestly something I didn't know till I did it basically in grad school, to be honest. So it's just one of the new places where you do a lot of things. And, as the video showed, sometimes you're integrated into a primary care clinic or a pediatric clinic. And I really like what they said, people don't know who the people in the waiting room are there to see. So it takes away the stigma, right? They could just be going to the normal doctor. Or the other advantage of that is then they just walk that person down the hall, right? You don't have to refer them to somebody else and try to get them to go to those appointments. It's right there. So I think that is a really important piece of it. But yeah, then there are people who work at the VA and hospital settings and all these different settings. It really is one of the largest growing areas, especially if we think about sort of the geriatric side of things, right? So the baby boomers are getting up there, right? They're in their 60s and 70s now. And so they all need geriatric care. Some of them are starting to have dementia issues, other major health issues, right? And so, most people aren't typically woohoo, I want to work with people with dementia, right? It's kind of depressing, to be honest. But if you are intrigued by it or think, that that's something you want to be interested in, that is one of the places where there's huge career growth. So that's something else to think about. All right. Any other thoughts about health psych as a field, thoughts, questions before we start moving on to some of the other readings? Alrighty. Well, let's talk about, I think this one was really important, the one on the behavioral economics, right? Or economics of behavioral health, rather. Because I think it is important. How do you get insurance to pay for this, right? And how do you make sure the person gets reimbursed? And, also that you're not charging people an arm and a leg for something that they didn't even anticipate doing when they walked into their doctor's appointment, right? So what were your thoughts and reactions to the Blount? I don't know. Lunt et al. Article. Yeah, I mean, you're going to do more reading about this for Wednesday, but managed care is unfortunately a reality of practicing psychology. A lot of times who you can see is, and for how long, is not dictated by you, but by the insurance company.
Oh boy, insurance in this country. I don't know, like, it kind of reminds me of like when you like get your car fixed and like you're just trying to get one thing fixed and they're like, oh, but there's all this other stuff that needs to be done, or they try to like get you on different things. It just made me mad, like people just not being able to get access to healthcare that they need and like the quality and like and people and like and just like and like certain groups of people, minorities, like they tend to like not get the same quality of care. It's just ridiculous.
Yeah, it is a really good point. Yeah, that like people can't access services they need, right? And sometimes it's medical as well. Yeah, Miranda said you have something. Go ahead.
Of all places, I was actually on Reddit earlier, and I saw something that was here it is. I just found it. It is a thread, and it says, this mom is facing 27 years in prison after officials say she lied about her residence to get her 3 kids 10 care that resulted in the state paying $24,000 in fees and claims. If you look more into the story, she's facing 27 years in prison for searching for health care for her kids because she couldn't afford it. That's longer than the sentences that some people get for like murdering people or raping people. And she was trying to secure health care for her children. Like, pardon me, but what the hell?
Well, like I remember I've seen stuff of like, and it's just mind-boggling to me as an EMT. It's something I hate to see. Is like people taking like an Uber, having their friends drive them to the ER when they have like a serious health issue. Like, no, like you need emergency medical care. Like, so, yeah, sure, you get a black eye or a broken nose. Yeah, you can have your butt, you can plug your nose up and have you drive to the hospital. You got a broken leg or an extremely deep laceration or something, like you need an ambulance. It's so sad that some people will intentionally avoid it to not pay. I mean, it's expensive. It can be a few grand, which is nuts.
Yeah,
sorry.
Flipped off her bike and had to take an ambulance, and she was from Canada, so like her insurance was sort of, you know, just sort of the international student one, and it obviously could, you know, could have been really an issue, but she was able to work with the hospital. So, Miranda, did you guys before I switch over to Jess? You seemed like you were going to say something, and I interrupted you, so I just wanted to double.
Sorry.
No, all good.
My dad, over in about January, was really sick, ended up having to get Dilaudid for it at the hospital. But he was so sick that he decided to take an ambulance purely because he was afraid he would die on the car ride and his wife would be traumatized.
Yeah.
Like he did not want to take an ambulance because he didn't want to pay for it. And he still wouldn't have if there had been anyone other than my stepmom to drive him. But because he was like, if I die, she'll never forgive herself. That's why he chose to take an ambulance.
Yeah, very sad. Yeah, Jess, go ahead.
Well, I was just going to say that one of the other problems that I find with the, like the behavioral health services is, and that nobody knows how to get to them. Like, you know, a lot of people might think, okay, if I go straight to the hospital, that might be somewhere, or, you know, like there's the LGBT, the Life Center, whatever, that has access for those people. So that's a good resource. But I think that there's just a lack of knowledge of just where to go for mental health services.
Yeah, that's a really good point. And that's one of the reasons that they are trying to like integrate more into primary care so that the person's just right there, right? But yeah, like accessing mental health services can be nearly impossible. So I tried to help a friend of mine who needed a therapist. And you just get this giant list from your insurance company. And then like I was trying to look these people up because like I clearly don't know every mental health professional in the area. I know like 4, right? And most of them didn't have a website.
Yeah,
like,
this is the list I was given for Cocoa, like all of these, and half of them that I've called, like they're not taking any more patients, right? The list has like she's out because she's pregnant, and you know, it's so hard to get anybody. Luckily right now with the telehealth, I can make him an appointment for like Chesapeake and not have to drive. So that helps right in this moment, but it's just so difficult to access anybody.
Right. And if you can find someone, do they know about the issues that in particular Coco's facing, right? So yeah, that can be an issue, right? Like if you go to just any therapist, right, and they don't have specialized training in, working with people who are part of the LGBTQ plus community or working with people with eating disorders, for example, then it could actually honestly make you worse, not better. So yeah, Zoe and then Colin, go ahead.
I have a question. I want to get into more of like people with hearing impairments or being like speech problems. That's why I want to be a sign language translator. But then would that be under health or would that be under neuropsych? Because I'm doing the neuropsych week and I was like, oh, this is gonna be so cool. And then I was like, oh, this is like the research part. And I was like, oh, less cool because I don't like researching. I like hands-on. So I was like, rats. So would like language be considered under health or would that be more of clinical? Or is that just the same thing?
Good question. Yeah, so it is, they all fall under clinical or counseling. Yeah, so you could specialize from that into health, into neuropsych. There are neuropsychologists who just practice all day. They don't all do research, and some do a mix. But yeah, and then I actually don't know. So in terms of, I actually worked on a blind rehab unit, so, maybe similar. And it happened to be a unit that was in the same facility at the VA. And so the psychologists had offered their services. So yeah, I think it would honestly sort of depend on, it might end up being like a private practice thing where you advertise that you are fluent in sign language and you specialize in that. Or it could be that, you work in a center that works particularly for that with doctors and whatnot. So yeah, I mean, there's not necessarily a clear path for all of these things because, again, even though this one article was written in 1990, it's still a pretty new subfield and we're still sort of figuring out the logistics, partially because of stuff like how do you actually get reimbursed for it, right? Yeah, Colin, go ahead.
You're kind of like on what you mentioned with like, difficulty getting a therapist. Like I was trying to help my best friend at one point find a therapist, but they were trying to find a trained and LGBTQ minded therapist. And that's even harder. And then you got to find one within your insurance and that's taking patients. And even in DC, a super pro LGBTQ city, almost all around, it's still not an easy thing to do.
Yeah, in this area in particular, I think there are only a couple people who have that skill set and that particular knowledge. And like, I'm not going to be knocking a competing institution for no reason. I want to put it out there, but like a lot of the people around here have their degrees from Regents, right? So they're probably not getting the training in terms of supporting those people. I'll put it that way. And individually they could be different. I definitely saw at our state conference one year, people from Regent posted or doing a poster about LGBTQ issues, and they did seem to be more from the empathetic side of things. But that's one person as opposed to everybody. So yeah, it can be hard to find mental health care in general. And that's one of the reasons why we're trying to just integrate it more. Because, you know, if you're in the hospital, right? Like, for example, when I was in the hospital to have Quinn, you know, like everything was just covered under my copay for those days, right? And so, like, didn't matter how many times the lactation consultant came to see me, or, you know, like Quinn's pediatrician came to see us, you know, that was just sort of covered. And so the same thing can happen when you're hospitalized for other things, where it's just sort of like any specialist you see while you're there is just covered under your copay. Again, as long as you have insurance, right? If you don't, I ended up having to have a C-section with Quinn, and I got a, you know, the explanation of benefits, it would have been like $25,000 if I didn't have health insurance. We did not pay anything near that, for which I'm very grateful. But yeah, it's not cheap. Our system was not great. Yeah, Miranda, go ahead.
In that vein, several years ago, my mom spent time in the hospital, and she actually did have health insurance through the state. She had just gotten it. She had just gotten a new job, but she spent 9 days in the hospital with severe breathing problems. So she was on like breathing treatments every few hours, and it was a mess. And she was there the first time for like 9 days, and then had to go back for another like 6 days after that. All inpatient with, like, you know, imaging and all that fun stuff. And the bill came out to be something over like $36,000 with insurance. And we had to, you know, file all this stuff with the hospital trying to get the bill down. But even then, with all of it, her credit was so bad that she couldn't take out loans for me for school anymore. So I had to, it was directly a causal relationship that's causing me to have to pay for school by myself. It's not that she didn't want to help, she physically cannot. And, you know, that's just, how do we let our country do this to us?
Yeah, I don't remember the exact statistics. I'm Googling it like while I'm talking. I'm trying to Google what the percentage of, so 41% of working age Americans have medical bill problems or are paying off medical debts. And that was before COVID started, right? So yeah, it's a huge chunk of the number of people who have debt and the debt that exists. So, yeah, it's very problematic. Colin, go ahead.
Yeah, kind of piggybacking on what Miranda said, you know, two things. One with, you know, so I had family who went to Hopkins. They had pancreatic cancer. They had operations and treatments, all different medications they had to be under and everything. They were there for a little while, but, you know, luckily their insurance covered it. But when they came out of Hopkins, their bill was over $300,000. Like, cancer is expensive as hell, and it's not even like your fault. Like, the only time you could even remotely be considered your fault is if you smoke 2 packs a day, and besides, that's correlation, not causation. And also, like with COVID, I saw an article. There was an older guy, I think he's like late 50s. Went through COVID, had to be on a ventilator for like 6 weeks. They said the doctor just throwing everything they had at him to try to keep him alive. And he did live, and he was going to be okay. But I saw an article that said he thought he'd have to go back to the hospital after he saw the bill. It was $1.1 million. And like, again, he had insurance, but like, holy, like, yeah, pardon my language, holy shit, 1.1 million.
Yeah, part of the problem with insurance, in addition to not always covering mental health or physical health, even though they're supposed to under the ACA Obamacare, is that it's supposed to like keep the market competitive, but it really doesn't, because everything's so cloak and dagger, right? So for example, you know, I've seen lab work, blood work I've gotten and they charge the company $300 and they pay, the insurance pays $7, right? But were they to charge that to someone without insurance, they would just charge the $300, right? They're not charging the $7. And so it's like we're passing it off the payments to the people who really can't pay it. It's sort of insane. Yeah, Kenzie, go ahead.
So a few months ago, I went to the ER for a ruptured spleen, and the emergency room said that I needed an emergency CAT scan, and that insurance, we have insurance obviously, and they said that most of it would be covered. And so we get our bill like 2 weeks ago, and insurance, I guess, thought that that wasn't really necessarily an emergency. And so they said that they weren't going to help pay it as much, and we still owed like $10,500. And so now we have to go back to the ER and explain to them that they told us that our insurance would pretty much cover a lot of it, and that it was an emergency because I had a ruptured spleen and they needed to see what was wrong. But then our insurance basically was saying, well, to us, that's really not an emergency. So now we still owe like $10,000, and that also made me have to take out extra loans because, I mean, I have a single mom and a little sister. Like, that's a lot of money just for one ER visit, and I was only there. I didn't even stay overnight. I was only there for like, I mean, pretty much a full day, but still, $10,000 is a lot, and but.
Well, first off, I'm glad you're okay, Kenzie.
Thank you, me too.
Rupture. Anytime any internal organ ruptures, it's bad, right?
Yeah, it was definitely not fun.
But what I've been told is that just keep calling back and arguing with your insurance company, and eventually they'll pay you. So don't give up.
Yeah, that's what my mom's pretty much trying to do, because she's like, that's just outrageous. $10,000. I mean, that was not worth $10,000.
And the ER is, they can sort of also go to bat for you. So hopefully you can get the doctor that treated you and do that.
Right.
Yeah. But yeah, I mean, like, again, like psychologists are having to do this for mental health care. And then again, if you're integrated, you have to figure out the logistics of that. But sometimes it's easier because there are like medical psychology billing codes. You just have to know them. Yeah, Miranda, question. Go ahead.
Yeah, how is it ethical for an insurance provider who is not a medical professional to argue with the medical professional and state that they don't think something's an emergency or that it wasn't medically necessary? Like, they don't have those qualifications and those certifications. How do they, how?
Exactly, and that's kind of why my mom was so mad, because she was like, how are you going to tell us that that wasn't an emergency? But we had to, I mean, I was in so much excruciating pain, like, it was miserable, and I was like, okay, if I didn't go to the emergency room, something more could, like, more complications could have, like, arise from that. So it's like, how can, basically what you just said, like, how can an insurance company say that, oh, we don't really think that's an emergency? Like, but yeah, I definitely agree with you on that one.
Yeah. I am going to hit up the questions in the chat. So Megan asking about insurance companies don't allow coverage for pre-existing conditions. So again, ACA, the Affordable Care Act, Obamacare changed that. So this is one of the reasons why people are arguing against any time they try to repeal it, is like, okay, then do you want someone who has a pre-existing condition to not be able to get care? Yes, Zoe, there are contracts, and they're insane. The contracts between medical providers and insurance companies are very complex and constantly changing. I have a friend who, this is his job, is to like keep track of this stuff for Centera, basically. And he said it's just like, especially right now, because, everyone's trying to sort of figure out how they're going to cover everything in the pandemic. He said, like, this changes every week, like all the policies. So they have to like re-enter stuff in the computer, keep everyone up to date on it. So Greta, go ahead.
Like, going off of what Kenzie was saying, how like they said it wasn't a medical emergency. So I know there's like some patient first, like if you call them and like you ask like, should you come in because COVID and everything, you don't want to be exposed. And like I remember I called them the other day and they were like, oh well, like you need to determine like if you think this is life-threatening. It's like, I just think that's like interesting, because it's like you're calling a nurse to like ask like, should you come in? And they say like you should determine that yourself. So like I'm just like curious, like I wonder if like people have done that before, and like they don't come in, or like they do come in, and like it just has like psychological effects because you're calling like the doctor to like ask like if you should come in and be seen. But like I don't know, I just think like our healthcare system is like really interesting.
The other crazy thing, just to add on to that, was that we actually went to a patient first in the beginning, and they ruled it out that it was just like a stomach infection, and that like if it didn't go away in like the next 3 days, then I would go see an emergency room, because obviously it wasn't. So then I called the emergency room and told them my symptoms, and they were like, you need to come in like immediately. It sounds like you're experiencing a ruptured spleen. So the fact that I went to someone that wasn't like just like a primary doctor first, and then I went to the emergency room, and then having to deal with them saying that I wasn't an emergency with my insurance is just outrageous to me. It just doesn't make any sense.
Sorry, I was typing when I could have been talking. Yeah, so mental health is an issue. Yeah, all of these things are an issue because of the way our health system works. People are hesitant to go in and get stuff treated sometimes, right? Yeah, Zoe, in terms of like proposal for even more affordable healthcare, you know, Medicare for all is one of these proposals. You know, I haven't looked at, you know, Biden's ideas, if he has ideas for bringing down costs. I mean, a big thing is to do regulation of cost for things, particularly tests and medications. Oh my gosh, like we've all heard the horror stories, right, of people jacking up the price of medications just because they can. Like I have to carry an EpiPen because I get allergy shots, and even with my insurance, it was like a $300 copay because they jacked up the prices. Luckily, there's a generic now. But yeah, so like some people are trying to come up with solutions for this, but people are really resistant, even though we're one of the only first world countries that doesn't have nationwide healthcare, or what some people call socialized medicine. And obviously those aren't perfect. If you need anything elective, you end up on a list in places like Canada, but you walk in and you don't have to worry about getting charged for things, right? Because your insurance covers it, and the taxpayers pay for it. So yeah, it's a different philosophy, obviously. Yeah, and the idea of like not being able to see things on x-rays, right? Yeah, that gets tough, you know, as a psychologist. You have to really advocate and show evidence sometimes for, you know, the fact that this person does need your help. So that can be tough. And it depends on the person's insurance, you know, something like an adjustment disorder, for example, which is just, I'm having a really shitty time right now, and so I need therapy because of that. Sometimes insurance doesn't cover coverage for them. So then the therapist has to decide, you know, what else does this person have symptoms of and what can I diagnose them with? And, you know, without committing insurance fraud, right, obviously, but to make sure that they can get care. Because again, it's really pricey, as we're talking about, if you don't have insurance. And I think I've told you this when we went over the syllabus, but I had a client who saw me, had to pay out of pocket both for my time and for like a facility fee. And you get that for the hospitals too. Okay. So health psychologists are also trying to help with stuff like this, because a lot of what they're working on is preventative care and behavioral change to help people not end up needing the doctor for things. So things like smoking cessation programs, things like, you know, how do you make sure you're following your medication regimen? Things along those lines. Just offering, again, like support. So when I worked in the HIV clinic, we would go in and see people who are newly diagnosed, right? Try to sort of head things off at the pass. And we really saw a gamut of different things there, you know, like from people just sort of like in shock taking it, this is the first time they've been diagnosed, to, you know, one person I saw was just self-medicating really heavily with drugs and alcohol. And like, because of that, was like having illusions and hallucinations. But but they were all substance caused. And then, you know, to just depression, lots of status. So one of the folks I saw was a minister in a small town, and he'd been on the down low, and so he had it, and like his wife was gonna have to get tested too. And so now, you know, he basically knew his small town Georgia, right, church wasn't going to let him be in there anymore if they found out. So sort of navigating that. All the way to, like, a friend of mine had to walk somebody down to the ER from that clinic because they were fully manic, and like skipped into the ER and said, like, this is a lovely place you have, right? So yeah, you have to kind of be prepared for any of that. And oftentimes when you're doing this type of evaluation, you have maybe 10, 15 minutes with the person, right? So what can you do in that short amount of time? So we would have like handouts. We might do like quick screeners, like the Beck Depression Inventory. We did that actually for 3 of the clinics I worked in, the HIV clinic, the breast cancer clinic, and the MS clinic. In the MS clinic, we would also do cognitive testing to see how their memory was being affected, things along those lines. But actually, a symptom of MS is symptoms of depression. So we would definitely have to screen for that there. Yeah, it was interesting for me because the different populations I worked with, like the people who were most resilient were often the breast cancer patients. The blind rehab people were like fine. They were all like, yeah, no, it's cool. Let me tell you my story. And so I would just like hear their life story. Like the guy who, when he was in the military, he just like spent time in Alaska. And he's like, the only time I carried my gun was to walk the kids to school when there was a wolf near the village. Okay. You know, to, you know, people just rolling with it. And then there are people who have really hard time adjusting. I had a 17-year-old, maybe 18-year-old, but he got his spinal cord injury during basic training, fell off the climbing wall. So again, imagine you're younger than you all by a few years, and all of a sudden you now have a spinal cord injury for the rest of your life. So a lot of it's about, you know, again, trying to get people to do the things they need to do for prevention or to do maintenance for things. And again, sometimes it's stuff you don't expect. So one of my supervisors on the spinal cord injury unit was the one who talked to all the guys about sex because none of the physicians would. So it's just sort of this assumption, I think, that like they wouldn't have sex because they had a spinal cord injury, which, you know, humans can be sexual creatures, right? So she would talk to them about penis pumps and all that stuff. And so she had to sort of self-educate because no one else would talk to them about it. So it's a very varied and exciting job, I would say. And again, like I said, trying to do a lot of prevention work, both in research and in application to try to keep that going. Ooh, good question. I would guess pretty involved, but I don't actually know since the opioid epidemic is not my area of specialty, so I'm gonna Google it. But certainly psychologists are involved in drug treatment. For example, typically you are working with psychologists in those inpatient facilities as well as medical doctors because of the physiological problems involved with withdrawal from those things. But yeah, so I'm going to do a health psychology opioid epidemic. Let's see what we find. Psychology's unique role in understanding the opioid crisis, says the APA. So I'll throw that in there. Yes, yeah. And so, yeah, a lot of the opioid epidemic actually is pain meds being abused, right? It's not, you know, that they're going out and getting it on the black market, or sometimes they are selling what they've been prescribed, but a lot of times it's just, they just keep taking more than they're prescribed or things along those lines.
Put out with the prescription medication, and then it's too expensive on the street, so they buy heroin.
Exactly. Yep. Because heroin can be cheaper. Crack cheaper.
I actually have a story about this almost exactly. Is that a family member of mine was abusing trazodone, or excuse me, tramadol. It was the pain medication tramadol. And he has a bulging disc, so he actually like is in a lot of pain and does need pain medication. But his psychiatric provider was the one who actually encouraged him to get clean because he could not take tramadol and an antidepressant at the same time. Like he would not, he said, I'm not prescribing you polypharmacy. Like you have to get off of this if you want to get on this. And so it helped him to kind of get clean because while he did need the medication, he was horribly overcompensating and definitely using more than he needed. And has just kind of figured out how to treat his pain in different ways.
And then I said I'm muted again while I was muted because you guys could hear me. I'm glad you brought that up, Miranda, because this is also another area of growing expertise for psychologists is pain management. So there's a lot of pain management centers now where psychologists help people deal with their pain through a combination of often medications and behavioral things. So relaxation techniques. Sometimes people just need therapy because sometimes it's like the stress is manifesting as the physical things perpetuating. And you can also do other things like, mindfulness meditation, hypnosis, things along those lines. Megan, go ahead.
So I have kind of have an answer for the opioid epidemic. I don't know so I worked I worked in a place that helped people who were suffering from substance abuse. But we were more of a stepping stone place because we would take people who couldn't get into a long-term rehab right away or emergency situations. So I don't know if my coworkers, I know they were licensed LPCs, is that the acronym? Yeah, I know that's what a lot of their certification was. I don't know if they were quote unquote health psychologists, but there were people who led group therapy every day. There were therapists who did telehealth. We had two and then we had a couple therapists on location. One therapist who would come to the clinic once a day. So a lot of therapy was going through and allowing the people to sit down and talk in a case by case basis. And also providing any medication that they needed, Librium if they're going through alcohol withdrawal, that kind of stuff.
Yeah, and Megan, you kind of bring up a good point. Those people were certainly doing health psychology, but they might not have been labeled as health psychologists, right? You're not always labeled with this, even if this is the work you are doing, because again, it's rare to have actual health psych programs. Like I said, there are some masters, but typically you are doing something more broad and then specializing in this. So yeah. Let me see, someone else had something that you all wrote lots of good comments here. Colin, go ahead.
Yeah, kind of like what I put in the chat. Yeah, I had a family member, he herniated a disc, and if anyone doesn't know what that is, it's basically you rupture the cartilage between a vertebrae, and it's extremely painful and takes a lot of physical therapy to heal. And while he was in physical therapy, he got the pain medication, and then as someone who's been through physical therapy, this is the worst thing you can do with any kind of injury is as soon as it starts to feel better, you stop. Or you're sick and you take medication, you start to feel better, you stop taking the medicine, and then you're really screwed. And a lot of times what those pain medications also do when you get addicted to them is it'll increase the perceived pain. Your body will do that to make you want to take it again and keep taking it. My uncle went to rehab and got off it. He said the pain started going down because, your body, someone who's a stress smoker, I would get really, really anxious if I didn't smoke that long, but if I just kept going with it, my anxiety would keep going down. And so, your body will manifest those things to keep you on that habit, which is really hard.
Yeah, Colin, that's a really good point. And you all are having really good chat about opioids. Yeah. So this is what's tough, right? Is we can't just like out and out ban opioids because they can be helpful. And in fact, if you take them as prescribed, they can actually help with things like inflammation as well. So there will be people who not only stop their physical therapy, but stop their medication before they should because they're worried about getting addicted, right? And in fact, that can be more detrimental because then, like, again, the inflammation isn't going away. And so a psychologist can work with people on that, on like kind of working around like, okay, so you have to take it as prescribed, and here are like the signs to look for. But yeah, essentially, the reason all of the pharmaceutical companies are getting sued over this is they were telling doctors like, there's no side effects, there's no way people get addicted, it's fine. And obviously, clearly, that wasn't actually the case, right? So, and you know, people are winning these lawsuits, not surprisingly. Yeah, exactly. So it is a huge battle. Any type of substance use, it's a huge battle to get over. And then oftentimes, what you really need to address is why that person is abusing substances, right? So, when I was at the VA, there were guys, so I was there in 2009 to 2010. There were guys who had been in Vietnam, the late 60s, early 70s, who were just coming in for treatment for PTSD for the first time because they'd been abusing alcohol or drugs so long to essentially control their symptoms of PTSD. And when they finally got clean, they're like, oh, I'm having nightmares, I'm having flashbacks. So yeah, and people will, you know, when they're stressed, when they're anxious, self-medicate with this stuff. And again, it can get really tricky. You know, as I mentioned, when I was in grad school, we saw anyone who came in with any drugs or alcohol in their system. And one of the patients who will always just be cemented in my mind is there was a woman who was an exotic dancer. And she said, yeah, I have to like do shots and take cocaine before I go on stage because I just feel like a piece of meat when I'm out there. Right. And so just like knowing that this is how she got through everything, you know, was hard for her, awful. And so, you know, again, you can only do so much to support them there. And the nicest thing that can happen when you're a health psychologist and you have those settings is if you can like continue with the people. So again, these people who are integrated into primary care have that opportunity, which is really great. Or if someone's in the hospital for long term, you know, like sometimes the spinal cord injury folks should be there for months, so I get to see them over and over while I was on my internship. You know, that's great. Or I had someone that I saw who did actually have a cardiovascular issue, but in addition had panic attacks. So I saw him in the hospital, and then he actually came to see me for psychotherapy at our outpatient clinic after that. And that was really great to be able to follow up with him. But that, like I said, they don't always do that. So actually that was kind of funny because he didn't recognize me, because when I rounded in the hospital, I always had my hair up. And then I came out like this and he was like, oh. So yeah, Colin, go ahead.
Oh yeah, also like one other thing with also the opiates and stuff and with health psychology, it's like I had a friend who got, you know, top surgery, it's a reconstructive surgery for people who are trans. And when they left the hospital, they got a whole prescription of like a full bottle of Percocet, you know, a high strength opiate, and it was causing them like a lot of issues and side effects. And they went back to the doctor to talk about it. And when the nurse went and talked to them, they were really confused. Like, you should have gotten a Percocet prescription. You should have gotten like 500 milligrams of ibuprofen. Like, and it's just that you shouldn't even have been prescribed this. And so it's just like, how the hell does something like that happen? I mean, luckily, you know, my friend, they didn't like taking it. It caused, you know, those opiates do cause a lot of constipation and other issues. So, you know, they was like, I don't want to take this. And I was happy about that. But like, yeah, it's overprescribed too.
Yeah, definitely. That's a really good point. And this is another place where psychologists can be helpful in health psych, is that some psychologists actually study things like that. Like, why do people get prescribed the wrong things? Or why do doctors make mistakes when they do surgeries? And so psychologists have been the ones who have really been advocating for, you know, doctors not having, you know, 48-hour shifts or whatever, because sometimes those things happen just when people are tired, right? So, study came out while I was in college that the effects of sleep deprivation on your brain are identical to the effects of alcohol. So it's like being drunk. So imagine trying to prescribe medication to someone while you're drunk, right? Like they shouldn't be doing it. So they shouldn't be doing it sleep deprived. And yet our training model expects them to, right? Like that's just part of the process. And so that's why I liked how they were talking about in the one integrated care setting, they were actually training the doctors and the psychologists together, right? Because you start to get that integration. I was fortunate to, in 2 of the different settings I worked in, we actually worked with the psychiatrists, their residents. And so we were able to sort of learn from them and they could learn from us. And that was really great. So I learned a lot about psychotropic medications and, you know, so how do psychiatrists try to monitor this stuff, right? So like, okay, if you use up, you know, your Xanax in 2 weeks and it's supposed to last a month, then like, I'm not going to refill your prescription because either you're taking too much or you're selling it to somebody else, right? And like those tough calls that they have to make. Well, let's talk with our last 10-ish minutes here about the cultural adaptations of behavioral health interventions article. Again, I want to keep coming back to, you know, racial issues and how they've been ignored and other cultural issues. And what were your thoughts about adaptation? Is this something that you had thought about, and how can we do this well? What do y'all think?
I mean, I think it's really important that we are able to provide mental health care in all different cultures for all different races and ethnicities. It's unfortunately common for a lot of Black individuals that the general consensus is that you don't need that. We don't need another stigma against us.
I think that it's been really evident with COVID happening. I know that a lot of the Latin American community, they're saying that it's prevalent in them, but they're saying that one of the reasons is that they weren't getting the information in their language. I saw a thing that Matthew McConaughey like did this whole thing for them in their language because he knows Spanish. And so he worked with somebody else in their community, and they made it easier for them to understand. But it really kind of brought to light like this article, the adaptations, how we just don't address to everyone.
Yeah, and like how we have to frame it, right, for people, you know, and give everybody access to the resources. Yeah, having the translation. You know, remembering our Native American populations and making sure tribal clinics have the resources they need, not just sending them body bags like they did when they asked for COVID tests, right? Yeah, I really liked the part, it's at the bottom of page 197, where they talked about like, how can you tailor these messages? So you're giving the same information, but you're just making it accessible, right? So they talked about, if a woman is age 40 or older and has not had a mammogram in the past year and agrees with the statement, when I am ill, I pray for healing, her magazines would include a story built around the following concept. The Lord has given us a powerful tool for helping find cancer before it's too late. Getting a mammogram together with the power of prayer will give you the best chance to live a long and healthy life, right? And so then even as you as a practitioner don't necessarily have the same religious background, you still recognize that this is a way that you can connect with that person and you know, help them conceptualize it. You know, I think a lot of folks of any race who are very religious, right, just think like God will provide, right? And it's helping reframe medicine as God is providing this, right? You know, like this is something that, you know, the scientists have been blessed with being able to do. Yes, Miranda, what you said is a comment. Yes, socioeconomic status is a huge contributor to that. These populations are much lower socioeconomic status. They're much more likely to be working in frontline jobs, and they're much less likely to have access to adequate health care. So psychology, especially the APA right now, is really trying to buckle down and focus on remedying health disparities. And it was like disheartening to see that even in the 1990 article, they were already talking about health disparities. So we've known this for, you know, whatever this is, 30 years almost, and we haven't really done anything about it. Yeah. Miranda, go ahead.
And regarding, cultural tailoring and things like that, I don't remember exactly what it was for, what it was called, but I want to say a year or two ago, there was a talk in Blocker where this group of, they were Christians, but they were a denomination of Christians that didn't believe in modern medicine at all. And they were talking about, how, prayer for healing and refusal of modern medicine was kind of in their, I think so. But I had like a huge problem with that because there really is no cultural tailoring. And I think ethically there's a problem in that one of the things they were talking about was discussing, children that did not choose to be born into families of Christian Scientists and are now struggling with diseases or cancer or, other illnesses and aren't being treated because they're being prayed for, which I am not saying that prayer is inherently useless or a bad thing to provide for people in need. Religion is a wonderful source of comfort and healing for people, but modern medicine shouldn't necessarily be, scoffed at and looked over just because of your specific beliefs, Like there is no tailoring for people who absolutely outright use it.
Yeah, there have been some interesting court cases related to that about, they bring these people up for neglect or child abuse. Yeah, and so it's about framing. It's about figuring out how to present things. The other example I like that they gave is, in West Virginia, they tried to talk about sex risk reduction, and they had a giant display of condoms, and no one would come to their table because that was just such a big turnoff for everybody, right? Yeah, it shouldn't be, but if it is for people, it's not you can't beat people over the head with this stuff, right? You've got to figure out ways to get them to psychologically approach it and feel comfortable discussing these things and willing to take in interventions. And if you're just I know the way to do it and this is how you do it, then you might risk alienating people. I'll give you another example. So when they were still trying to make the adult studies program a big thing here, it's now called the evening and weekend program. The director at the time tried going to local community centers and presenting about, coming to Virginia Wesleyan to get this type of education. And he said no one showed up. But next door, there was a job fair type thing, writing a resume. It was packed, right? So you have to recognize people in that scenario, might not be able to pay even the reduced fees that adult and weekend have, right? So that might not be who you want to approach at this point, right? Approach them once they've gotten the job, right? And can pay the fees and things like that. So yeah, I think that that's a really important point as well. Any final thoughts about, cultural things here, ways to best approach people? So no, you don't have to rate me. You could rate me at the end of the semester in my evals or not. Some of you have heard me rant about evals before, that they're actually really biased against female professors and professors of color, surprisingly enough. So I personally haven't had a problem, but I feel like as someone who hasn't had a problem, I need to be the big advocate for it, because otherwise they'd just be like, it's because you get bad evals. It's because there's research that shows that it's a problem. But no.
Well, you are an amazing professor, in my opinion.
Well, thank you. And you have to say that because I'm so great at you. No, I'm just joking. All right. So Miranda's going to do the continuing health psych, talking about ethics with health psych, which we started. I mean, as you can see, these things are so intertwined. We kind of end up talking about each thing the next day. So if there's anything we didn't get a chance to talk about today, we could certainly do that then. Alrighty, everybody take care. I'll do my normal thing where I stick around for a couple minutes. And if anyone has questions about the internship stuff, I'd glad to talk about that now too.
I got to rush to my next class, but I'm definitely going to be emailing you this evening regarding that class.
Awesome. Yep. And we can set up an appointment if you want, or I can just send you everything you need in email.
Yes, ma'am. Thank you.
I had just one quick question. So I was Googling over the question that I had for the speech and stuff. So would that be like considered speech therapy or language? Like where would I go to find?
Yeah, that's a good question. So yeah, if you wanted to like specifically be a like sign language translator, right? That's different training. This would be a really good question for Jess Harrington, because I feel like she would kind of know how those things intersect in a really good way. And if not, she knows the resources to figure it out. So I would say if you haven't had your meeting with her yet, this is a really good topic to talk with her about in that meeting.
Thank you.
You're welcome. Sorry I can't be more helpful.
I had a question about the internship. So in the little form where you're signing up for it, when it says you have to pick your top 3, does that have to be out of the list that you presented in the meeting the other day?
Know of another site where you have connections or that you'd like, you can put that in there. Yeah, you're not beholden to those. Those are just places where I do have connections.
Okay. That's all I had. So
Oh, and I saw your other questions. Not really. I mean, we might get to talking to you if they're really, really bad, but as long as like you're consistently doing okay, at least you're all right. It's mostly if like, so I know of before I got here, there was a pre-tenure professor who got fired because he just didn't show up to teach class. So that's more the problem, obviously. But yeah, they're pretty understanding, especially if you only get like 1 or 2 bad ones. They know that it's probably typically not you. It's, you know, that particular student and you just weren't a good match.
Okay. Thanks.
Good question.
All right, and I just had one question too. It may be kind of like a silly question, but I was just wondering, so everything that is due, it's in the syllabus, right?
Correct.
Okay. I just wanted to make sure. I thought I didn't want to be like any hidden like assignments or anything.
No. Anything that changed, I would let you know, like in an email and whatnot. So no. So the first big things you have due are the meetings with me and Jessica, and then not too long after that is the interview paper.
Okay. Thank you.
The journals, which y'all are already doing. So.
All right. Thank you.